You can walk up over there and do it. Here.
It smells like appreciation.
Is this the slide advance?
We didn't get inside because we're not appreciating.
There's a pointer there too.
I can hold on to it. Good luck.
I think we'll wait a few more minutes to get started, but in the meantime, can I remind everyone in the room, please call the number in the back. Our remote clinics should also have a number or a sign-in sheet at their clinics, but if you call the number in the back and put in your event ID, if this is the first time that you're doing it, they will send you a text back to verify your cell number with the person so that they can give you credit. If you've done it before, then you will automatically get credit through the automated system. This is pretty much how we have gone to counting numbers for grand rounds also, so please go ahead and do that so that we get an accurate number count. Can I also remind everyone to please turn in your evaluations at the end of the session, because again, if we don't have evaluations for the sessions, we are not going to be allowed to do CME anymore next year. So please turn in your evaluations at the end of the session. I think I'll wait a couple more minutes to see. Okay. Well, I think we'll get started. It is my pleasure to introduce Dr. Madhavi Gavirneni, one of our senior pediatric residents graduating this year. Madhavi came to us in July of 2012 from having done her medical schooling in India from Rangaraja Medical College. And having finished her MBBS, she then did some observerships here in the US before joining us in July of 2012. And really, Madhavi has done wonderfully in the residency program and taken off as a star in our program. We are very, very sorry to see her go. During her time here, she was very actively involved in the Read and Play project with the department, and in combination with Dr. Jessica Albright, they submitted to the AAP and actually ended up getting the Ann E. Dyson Advocacy Award in 2013 for all of their work done on the Read and Play projects. It was a very interesting farmers market project, and it won them great accolades and acclaim at the national meetings. Since then, Madhavi has continued to do lots of oral presentations and has many papers through the department, and as well as also been involved in our QI projects of the department. Madhavi hopes to practice general pediatrics. Once she leaves here, she has a beautiful little daughter, Dia, and really actually hopes to catch up with some mommy time before she starts practice again. Eventually, Madhavi and her husband will be moving to Texas, and she will be practicing general pediatrics there in the next year. We will be, as I said, very sorry to see Madhavi go, but I'm very excited to hear her talk today on travel medicine.
Thank
Dr.
you, Dr.
Gavirneni.
Okay. Hello, everybody. My topic today is going to be about travel medicine, and I'm just going to talk about the basics that you guys need to know. First of all, I have nothing to disclose, thank goodness. And do you really want to attend grand rounds or go have some food? Okay, so according to the World Tourism Organization, about 990 million international tourist arrivals took place in 2011 throughout the world. And out of that, US residents itself made about 60 million trips with at least one night outside the United States. Your international travel basically includes any travel for business, adventure, adoption, visiting friends and relatives. And there have been multiple studies done that show most of the people don't seek any kind of pre-travel health advice, unfortunately. For you to get some pre-travel health advice, the CDC recommends that you visit either your primary care physician or go to a travel clinic at least 4 to 6 weeks before you travel to any destination, just to make sure that you are up to date on your shots and if you need any vaccinations when you're traveling abroad. As per the IDSA guidelines, you're supposed to evaluate their health, including their immunization history and any underlying conditions that they have. Look up their itinerary and pay close attention to the amount of time they're going to spend internationally, which season they're traveling, and what their accommodations are going to be when they travel. We discuss about any preventative measures that they need to take and how they need to access medical care overseas if they require it. CDC has a yellow book which basically has all the information on travel medicine, and that's been there since 1967. So for a pre-travel consultation, you basically talk about the past medical history, which includes age, sex, any medical disorders that they have, any allergies, and if they're taking any medications. You also take into account if they're pregnant, if they're immunocompromised, if they're old aged, if they're having any kind of neurological problems, if they had a recent cardiovascular or cerebrovascular event, any surgeries recently. Take into account their vaccinations and what travel vaccines they need to get before they go internationally. And also if they had any prior travel experience, just to make sure if they had taken malaria prophylaxis in the past and if they had any adverse effects with any of the medicines, how they do with altitudes, and if they had any illnesses when they returned back. You have to go into their trip details, focusing on their itinerary and see how many countries they're traveling and which countries. If they're going to a rural or urban location, how long and which season, as we discussed. Reason for travel, is it for tourism, is it for just adventure, is it for some medical tourism, is it for research. Travel style, where they're going to live once they go international, and what their mode of transportation is going to be, and how good the hygiene is going to be there, and if they're going to be involved in any special activities, as you can see there. And sometimes you can get stranded and there's nowhere you can go. Major discussion should be about your immunizations, malaria chemoprophylaxis, discuss how to prevent travelers' diarrhea and if they need any antibiotics to go with them in case they end up having travelers' diarrhea. Discuss about altitude illness, other environmental stuff like getting exposed to bites or scratches by any stray animals, walking barefoot and getting exposed to parasites, swimming in fresh water, which can make you at risk for schistosomiasis or leptospirosis. Talk about PPE for vector-borne illnesses, and sexual health and blood-borne pathogens if they get transfused. Your general recommendations for any kind of vaccination would be encourage people to get vaccinated on that day with how many ever vaccines they need to get. If, however, they're getting inactivated vaccines, they can be vaccinated at any point. It can be tomorrow, today, day after tomorrow, any point. But if you get your live vaccine today, then unfortunately you cannot get another live vaccine until 28 days or 4 weeks. With yellow fever, it is 30 days because then you're not immunized with your second vaccine that you got, less than 28 days. If in any case you get your second vaccine less than 28 days after you have gotten a live vaccine, you're supposed to be revaccinated again with the second vaccine after 28 days. If you're getting any kind of blood products or immunoglobulins, you can give your MMR and varicella vaccines 2 weeks before, or you have to wait anywhere from 3 to 11 months after. Once you have gotten your vaccines, it usually takes about 2 to 3 weeks for you to get an immune response. And there are some contraindications, which was interesting, which I did not know. If you're on any antibacterial agents that can interfere with your typhoid vaccine, specifically your oral typhoid. If you're on any antiviral agents against herpes, it can interfere with your varicella vaccines. And if you're taking any influenza virus antivirals, then that can affect your immune response to the flu vaccine, the live one. They also recommend that you don't have to restart the whole series of vaccine. If they have missed any dose, you just pick up from there. The exception to that would be only the oral typhoid vaccine, because with that vaccine, you're supposed to take a total of 4 doses, 1 every other day. But if that period extends for more than 3 weeks, you repeat the whole series again. Some people get PPD test done before they travel, and sometimes it's recommended 3 months after you come back from wherever you have traveled, if it's indicated. But if you have gotten a vaccine, then it's recommended that the PPD test be postponed, or the vaccine be postponed for at least 4 to 6 weeks. Your yellow fever vaccine is not valid if you get it less than 10 days before you travel. So it has to be given more than 10 days before you travel to the recommended locations. Some vaccine components can cause allergic reactions, and those include a vaccine antigen, animal proteins, antibiotics, preservatives such as thiomersal, and stabilizers such as gelatin. The most common allergen is the egg protein, and that is present only in your live influenza and yellow fever vaccines. None of the other vaccines have any egg protein in them. It was noticed that there were reports that if you were allergic to thiomersal, you could not be vaccinated, but CDC says that with the thiomersal, you actually have a delayed type of hypersensitivity, and it's not at all a contraindication for you not to get vaccinated. And also, since 2001, they have not been including thiomersal in the vaccines for infants. So it's safe for infants. Just going to go briefly over the vaccines. Your hepatitis B vaccine, you need to get at least 3 doses of the vaccine before you travel. Your interval between the first and second should be 4 weeks or a month or more. Between the first and the third dose should be greater than 16 weeks or 4 months. The third dose should not be given in any infant less than 6 months of age or 24 weeks. There's an accelerated schedule where you can get your hepatitis B vaccine at 0 months, 1 month, 2 months, and then when you come back, you get your 4th dose at 12 months. There's also a 2-dose series for adolescents aged 11 to 15, and that's separated by 4 to 6 months. Your DTaP, you should get at least greater than 3. If kids have not gotten greater than 3 doses, then you have to make parents aware that they might not have that much of protection against the pertussis. The polio vaccine is the same, the regular schedule, but if you have gotten 4 doses, with the 4th dose being below 4 years of age, then you need to get a 5th dose after age 4. And the dose duration between your 4th and 5th will be 6 months or greater. Poor kid, that's all they hear. Okay, your Haemophilus influenza, please do not administer it to any kids under than 6 weeks. because it might induce immune tolerance to the subsequent vaccines. And if their kids unvaccinated below the age of 15 months, they need to receive greater than 2 doses before their travel. That can be 4 weeks apart. And if they're aged 15 to 59 months, they can get 1 dose. And if they're greater than 59 months, they really don't need a dose unless they have any underlying conditions, which includes asplenia, immunodeficiency, immunosuppression, or HIV. Your hepatitis A vaccine, you cannot give it under 1 year of age because the maternal antibody will interfere. So if a kid under 1 year of age is going to a high-risk area with hepatitis A, you can suggest that the parents get immunoglobulin, not the vaccine. Your MMR vaccine can be given for a kid 6 to 11 months of age if they're traveling, but that doesn't count into your 2-dose MMR series, so they need 2 additional doses, one at 12 months and the other one at 4. And there's another vaccine actually called the MMRV, which has a combination of the varicella too. That's recommended for kids aged 12 months to 12 years, but they noticed that if kids below 47 months got the first dose of MMRV, they were at risk for seizures. So they said the first dose can be just given as MMRV and the varicella separately, but the second dose can be your combination of the MMRV. But if you intend to give your MMRV vaccine as the first dose, do not give it below 47 months of age. Then there's your typhoid vaccine. You have your intramuscular attenuated vaccine and the intramuscular inactivated vaccine and the live vaccine. The intramuscular one is recommended for kids aged greater than 2 years. And it's just a one-time dose, and they can get a booster again in 2 years. The oral vaccine, however, is recommended only for kids greater than 6 years, and it's a total of 4 capsules, as we talked about earlier, given one every other day, and a booster every 5 years if needed. And all 4 doses should be taken in greater than 1 week before they travel to an area at risk. Pneumococcal vaccines, if kids have been vaccinated with the PCV7 series, they should receive a dose of the PCV13 between the age of 14 and 59 months. If they're at risk for the invasive streptococcal pneumonia, like if they're immunocompromised or if they have asplenia, then it's recommended through age 71 months. Children who are greater than 2 years who are at risk for pneumococcal disease should also receive the pneumococcal polysaccharide vaccine, and that should be given 2 months after their last dose of the PCV13. And the second dose of the PPSV23 can be given 5 years after the first dose. That makes sense? Okay. This was interesting to note too. The influenza vaccine, if kids are aged less than 9 years and if they have not gotten more than 2 doses since 2010, then they need to get the booster dose, like 2 doses separated by a 4-week interval, which I had no clue about. So that was interesting to know. Your yellow fever vaccine is recommended for kids greater than 9 months of age, and if they're traveling to a yellow fever endemic zone, which is basically the equatorial South America region and anywhere 15 degrees on either side of the equator in Africa. If they're 9 months or less, then they're at risk for developing encephalitis from the yellow fever vaccine. So you could recommend the parents to not travel there during that age, or they can actually take precautions from the Aedes mosquito by just doing personal protective measures. Your meningococcal vaccine is recommended if you're traveling to the sub-Saharan Africa, especially during the season of December through June, and also when you're traveling to Saudi Arabia for your annual Hajj. There are 3 vaccines against meningitis. 2 of them are the conjugate, and there's the one polysaccharide vaccine. The conjugate vaccines are the Menactra, and you give a dose if they're 2 to 55 years old, and they get 2 doses if they're 9 months to 23 months old. The polysaccharide vaccine is only recommended for age 2 to 55 years. But if you think that a child less than 3 months of age is really at risk for the meningococcal disease, they can actually get the polysaccharide vaccine before they travel. And then there's the Japanese encephalitis vaccine, which is licensed by the FDA only for use in kids older than 17 years of age. Kids, in 2010, there were 2.2 million children aged less than 18 years who travel internationally, and 51% of all of them, or 32% who were visiting family and friends, only received pre-travel advice, compared with the 59% of the adults that got pre-travel advice. The most common problems in children that they encounter are diarrheal problems, skin problems from bites or scratches, animal bites, malaria, and respiratory issues. Going to talk about traveler's diarrhea. Traveler's diarrhea is actually defined as if you have greater than 3 unformed stools, including 1 or more enteric symptoms, and that's occurring in a traveler after they come back. Your traveler's diarrhea is mostly caused by bacterial pathogens, 80 to 90% of the time, 5 to 8% viruses, and 10% protozoal pathogens. Your bacterial causes are the regular E. coli, Campylobacter, Shigella, Salmonella, Aeromonas, and Plesiomonas. Viral, norovirus, rotavirus, and astrovirus. Protozoal, the most common being Giardia. Then you have entamoeba, Cryptosporidium, and Dientamoeba. Cyclospora can be seen if you have traveled to Nepal, Peru, Haiti, and Guatemala. Your signs and symptoms, you have to look for mild cramps to loose stools to severe belly pain, fever, vomiting, and bloody diarrhea. With viral pathogens, you encounter more vomiting than diarrhea, and your protozoal actually have a gradual onset and with low-grade symptoms with 2 to 5 loose stools per day. Your incubation period, bacterial and viral pathogens have an incubation period of 6 to 48 hours, whereas your protozoal can have anywhere from 1 to 2 weeks. Your bacterial diarrhea lasts for about 3 to 5 days, viral 2 to 3 days. Your protozoal can actually last for weeks to months without any treatment. There have been studies done that show for the prevention of traveler's diarrhea, you can actually take bismuth, subsalicylate, but it's not recommended for any kids less than 3 years of age. The problem with that is you have to take 2 tablets 4 times a day or 2 ounces 4 times a day. And it's a nasty medicine. It will cause black stools, black tongue. So I don't know how many people would take it. There are actually studies showing that the bovine colostrum is also a good prophylactic agent for traveler's diarrhea, but it's not FDA approved yet. Usually we don't recommend antiemetics for children, but there was a recent Cochrane review that showed that sometimes you can use antiemetics to decrease the symptoms in children, like Zofran or ondansetron, metoclopramide, or dimenhydrinate. Loperamide is not suggested at all for any kids less than 6 years of age. In the past, they were thinking of chemoprophylaxis for traveler's diarrhea, but then they found out that if we did that, the people ended up having resistance. So now they no longer suggest chemoprophylaxis for the traveler's diarrhea. Instead, you could actually provide the travelers with the medicines and educate them, saying that if they end up having diarrhea, they can take it for 24 hours to 72 hours. But if it's not resolving, then they need to seek medical attention. So the antibiotics that they prefer is azithromycin, which you can do 10 mg per kilo for 3 days, or you can just do a gram, 1 dose. Fluoroquinolones are usually used, but unfortunately we don't recommend it in our age group of children because it causes cartilage damage. However, the AAP suggests that since it's a short duration medication for about 2 to 3 days, you could do the fluoroquinolones since it's just for a short duration. If you have infection that's caused by multi-drug resistant Shigella, Salmonella, Vibrio. And how do you know that? I guess you just look at what's going around. In the past, trimethoprim, sulfamethoxazole, and doxycycline were suggested. Now they have found out that pathogens have become resistant to those organisms. So your number one drug would be the fluoroquinolones. There's actually a new drug called the rifaximin, which is a non-absorbable antibiotic, so it doesn't go much into your system and affect you. That's been approved by the FDA for traveler's diarrhea in kids greater than 12 years of age if it's caused by a non-invasive strain of the E. coli. It's not effective against any other organism like Campylobacter, Shigella, Salmonella. It's only effective against E. coli. The mainstay would be being adequately hydrated. They recommend ORS. You prepare your ORS by mixing a packet in the volume of water that's recommended on the ORS packet, so it differs. If kids are weighing less than 10 kilos, they need to take 2 to 4 ounces for every diarrhea or vomiting episode that they have. If they're greater than 10, then they need to take 4 to 8 ounces. Kids should continue nursing or formula feeding. Do not dilute the formula. And do not use foods high in simple sugars because it has high osmotic effect and it's not good for your diet. It's going to make it worse. Your foods high in fat will actually delay gastric emptying, so it's not helping either. Early feeding actually helps a lot. It decreases the changes in your intestinal permeability, reduces your duration of illness, and also improves the nutritional outcome. We have noticed that we sometimes suggest brat diets to our patients with diarrhea, but there's actually studies done that show there's no scientific basis for that and should actually be avoided. Now we'll talk about malaria. So your pediatric travelers who are just visiting family and friends are at high risk for malaria because they spend more time outside the country. You can do permethrin. You can apply it to their mosquito nets or clothing that they use, but do not apply it to the skin. The CDC also recommends using repellents which contain at least one of the listed, which include DEET, picaridin, oil of lemon eucalyptus, and the IR 3535. The Environmental Protection Agency states that each product has to have an age restriction listed on there. If it's not listed, then there's no age restriction. It can be given to any age. However, you cannot use any kind of repellent for less than 2 months of age. At that point, you just use mosquito nets and long clothing. And most repellents contain DEET as the active ingredient, so your protection varies with the DEET concentration. The more concentrated the DEET is, the more protection you get. However, if your concentration is above 50, it doesn't increase it. So up to 50, if you go higher, it will give you a higher level of protection, but at 50, it plateaus. The AP recommends for kids aged greater than 2 months, just use 30% DEET. And as we talked about, we should not use anything under 2 months of age. If there are children traveling to areas with dengue and yellow fever, you should use the same mosquito protection measures, but you should also tell the parents that the Aedes mosquito bites mostly during the daytime rather than the nighttime, which is your case with Anopheles. The dark red areas are the areas where you have your chloroquine-resistant Plasmodium falciparum. The light pink areas are the areas with chloroquine susceptible, and the white areas actually are not endemic areas for malaria. So that was interesting to know that South America actually has 2 areas, Chile and Uruguay. And almost the whole of Africa except for Libya, and the whole of India and China. The drugs that you can use for chemoprophylaxis are your atovaquone proguanil. You can use that for prophylaxis in all areas, and you're supposed to give that 1 to 2 days before you start travel, and you're supposed to take it daily at the same time and continue it for 7 days after you return. Your doxycycline can also be used in all areas, but you cannot give it to kids age less than 8 years of age. And that you take 1 to 2 days before you travel, take it every day on the same day, and continue for 4 weeks after you come back. Primaquine is used mostly for Plasmodium vivax, and it's for a short duration travel. You take that the same 1 to 2 days before you start travel, and you continue it for 7 days after you come back. Your primaquine is not indicated in your G6PD deficient children. Chloroquine, I don't know if we still use that as a chemoprophylaxis now, but if you do use it, then you give it only for chloroquine sensitive malaria, as we looked on the maps earlier. And you take that 1 to 2 weeks before you start your travel, take it weekly on the same day, and 4 weeks after you come back. Mefloquine, you give that in areas that are sensitive to the mefloquine. You take that for greater than 2 weeks before you travel. Take that every week, and then when you come back, you take it for 4 more weeks. It is not indicated in children who have neurological conditions because it can exacerbate seizures, and also if you have a prolonged QT, you don't take mefloquine. If you use a sunscreen and a DEET containing repellent, please do not use a product that contains both of them, because then you're going to be intoxicated with your DEET. So they recommend that you first apply the sunscreen, and then on top of that apply the DEET. And even if you do that, it decreases the effectiveness of the DEET by 1/3. So, but don't overuse it. There's some self-treatable conditions that I'm going to talk about. The first one is altitude illness or acute mountain sickness. When you talk about this, you're primarily concerned about hypoxia, and you get hypoxic if you decide to spend the night at high altitudes. However, if you decide to go to a higher altitude and come back overnight to a lower altitude, that really helps. It doesn't cause that much of hypoxia. Increase in ventilation is the most important factor in acute acclimatization. The tips you can provide to the families are, you can tell them to ascend gradually. You can ask them to consider using acetazolamide as a prophylaxis. Avoid alcohol for the first 48 hours. Do only mild exercise and do not stress yourself out. And also, if you think you're going to have a high altitude exposure, you can actually climb to higher altitudes for 2 days for 2 days in your 30-day period before travel. That makes sense? Symptoms you can have are headache, anorexia, nausea, fatigue, lassitude, and poor sleep. You can prevent acute mountain sickness by either taking non-opiate analgesics or antiemetics. You can also use acetazolamide, but it's more for prophylaxis rather than treatment. If you do need to use something for treatment, you can take dexamethasone. It is more effective than acetazolamide. However, if none of them are working and it's getting worse, just come back down. Jet lag occurs if you travel more than 3 time zones, and your symptoms with jet lag include poor sleep and sleep problems. You cannot perform well. You end up having fatigue, headache, stress, inability to concentrate, and depression. And you also have decreased interest in eating or decreased appetite. How you can prevent jet lag is you can start exercising, eat healthy, and drink a lot of water. If you decide to travel westward, you can shift the timing of sleep to 1 to 2 hours later. However, if you're traveling eastward, you need to sleep 1 to 2 hours earlier. During travel, avoid large meals, alcohol, caffeine. Drink plenty of water. Move around in the plane. Do not sit. It will protect you against DVTs. Wear comfortable clothing and shoes, and sleep. It's kind of difficult, but you need to sleep. On arrival at the destination, do not make any important decisions on the first day that you arrive. Just chill. Expose yourself to sunlight and eat at the right time. Drink plenty of water again. Do not drink alcohol. And take shorter naps if you really feel sleepy. Do not sleep for long, long hours. That way you screw up your whole sleep cycle. And then motion sickness. Children aged 2 to 12 years are more prone to motion sickness rather than infants and toddlers, which is good to know. Women are more at risk. If you have migraines, it's worse. If you're on any medications that can cause, it makes it worse. How you can avoid motion sickness: keep yourself aware of the situation. If you're going on a cruise, make sure you have what you need. And try to avoid situations that cause motion sickness. Sometimes that cannot be avoidable, like driving in a car. If you really have to do that, they say that you drive the car rather than riding in it. Also, sitting in the front seat of a car or bus will really help. And it was interesting to know that if you sit on the wing of an aircraft or by the wing of an aircraft, it actually decreases your motion sickness. I had no clue. Listen to music. Keep yourself hydrated. Avoid caffeine or alcohol. After they have returned back, they need to come and see you guys again. And at that point, if they're ill, you need to assess how ill they are. Look at their travel itinerary and go back and see how long they have stayed, which seasons they have stayed in, what kind of food they had, or what kind of water they drank. Timing of the onset of illness, their past medical history, and what medications they take, and if they did take any medications during their travel. Make a note of what immunizations they have gotten and not gotten, and also if they took any kind of malaria chemoprophylaxis. Fever in return travels usually manifest within the first month, but there are some infections that can occur months or even greater than 1 year after return. In the US, there are greater than 90% of cases of Plasmodium falciparum within the 30 days of return, but half of the cases of Vivax actually manifest greater than 30 days after return. So you always have to keep in the back of your mind that maybe they have malaria. Based on your geographic area that the travelers have visited, you can actually narrow down on your illnesses. If they have been to the Caribbean, South or Central America, they're at risk for dengue or malaria, especially the vivax. The other diseases that you have to keep in the back of your mind are leptospirosis, histoplasmosis, and coccidiomycosis. If they have been to Southeast, South Central Asia, then you have to keep in mind the same dengue, malaria, and enteric fever, but also chikungunya. If they have been in sub-Saharan Africa, you have to be worried about Plasmodium falciparum, period. The other things would be tick-borne rickettsial diseases, acute schistosomiasis, and filariasis, and African trypanosomiasis. Based on your incubation period, you can narrow down your diseases. Less than 14 days, chikungunya, dengue, encephalitis, enteric fever, influenza, legionella, leptospirosis, malaria, and rickettsial diseases. 14 days to 6 weeks, you can have the encephalitis, enteric fever, acute HIV, leptospirosis, malaria, hepatitis A or E, amoebic liver abscess, and acute schistosomiasis, or the Katayama syndrome. If it's greater than 6 weeks, then you have to think about amoebic liver abscess, hepatitis E, malaria, leishmaniasis, tuberculosis, and hepatitis B. I'm not going to go over the entire table, but this is a table that I got from the CDC website. So if you have fever with any other association, then those are the illnesses that you're supposed to think about. Most of the time it's malaria. Also, things to keep in mind, if you have fever in a return traveler, think of the common situations. They could be having a UTI, they could just be having a pneumonia rather than jumping to exotic diagnosis. People with malaria can be afebrile, but you will get a history of chills if they do have malaria. And take into account if they have taken any chemoprophylaxis. Even if they have taken chemoprophylaxis, sometimes it cannot protect them against malaria, so they might end up having malaria. Patients with malaria can have respiratory, GI, or CNS symptoms. Dengue is the most common cause of febrile illness for people who travel to Latin America or Asia. Your viral hemorrhagic fevers are important, but they're rare in travelers. The most common are the bacterial infections such as leptospirosis, meningococcemia, and rickettsial infections, which can cause hemorrhage and fever. So you have to keep that in the back of your mind. Those are my references, mostly from the CDC website, and then there's the Infectious Diseases Society. And that's my last slide. Any questions? Comments? Yes, Dr. Reagan.
Recommend treating all for diarrhea? Or it's mild, watching?
They recommend for mild diarrhea. If it's severe, then you need to seek medical help.
I mean, when they come back and we have a travel diarrhea, do you recommend treating all or just the severe forms?
Just the severe forms.
Do we have a lot of these vaccines in our clinic, or do you have to order them or send them to them?
You have to go to a travel clinic.
A travel
Yes, because the yellow fever, if you need the yellow fever vaccine, there are some guidelines that you have to fulfill before you can actually make your clinic certified to give the yellow vaccine. So
The health department here, and I think Kingsport has them, like I've called in the past, but you have to receive a certificate of vaccination, like Madhavi says. And that's why it's important to go to only those certified clinics to get it.
I think even the Red Cross does it. Yes, Erin.
So you said, if you're planning on traveling, to have the patients come in 4 to 6 weeks prior. Some of these vaccines have like a 6-month window between the first vaccine and the second vaccine. So do you just recommend, like, if they come in and they're traveling to one of these endemic areas, doing the first vaccine and then finishing the series when they get back if they're only going to be there for a few weeks or something like that?
Usually when you have patients come in, you have been following them and hopefully they're vaccinated.
Right, but if they weren't.
But if they weren't, then as per all the recommendations, except for your DTaP and polio, where you have to have more than 2, the rest of them actually say if you have 2, then separated by a 4-week period,
Okay.
it's okay.
So I think you can do an accelerated schedule, Dr. Aaron, to answer your question. So if you know that they're traveling as an infant, then you can accelerate their schedule, except the Hep B, which can be given before 6 months of age.
Right.
Or if you do give it, then you repeat it dose when they come back after your age. And separate them by 4 weeks, like she says. And then with the MMR, you can do the MMR early to cover the measles that is prevalent at like 9 months of age. But then when you come back,
Have to get the 2. That's all.
thank you, Madhavi.